Fran Feltner received her doctorate in nursing from the University of Kentucky College of Nursing and a master's in advanced practice rural public health nursing administration from Eastern Kentucky University. She serves as College of Medicine Assistant Professor, Family and Community Medicine and Adjunct Faculty, UK College of Nursing and UK College of Health Science. Currently, Dr. Feltner is the director of the University of Kentucky College of Medicine Center of Excellence in Rural Health, located in Hazard, Kentucky. Fran has worked for more than 30 years in rural health care, from serving as a nurse in clinical and hospital settings to her current role as director. One of her most important roles has been developing the community health workers' scope of practice and training curriculum for Kentucky Home Place. Since the program's inception in 1994, CHWs have provided over 4 million services and accessed over $256 million in services and medications for the clients in their communities. Kentucky Home Place has been recognized as a model that works and has been duplicated throughout the state and nationally. Please welcome Fran Feltner.
It is such an honor to be here today, and actually a couple of my dreams have come true in my life, and this is one of them, to be able to speak to you today. As we go through slides, I want to recognize just one thing before I get started. I do have a Remember This is Breast Cancer Awareness Month. I had an aunt that was an RN. She taught many years in the profession as a nurse, and she was lost to breast cancer when she was age 39. So I do dedicate this service today to her. So as we get started. This is Breast Cancer Awareness Month, and in Perry County we have a little campaign going on that says Paint Perry Pink. Everything that we do is pink. And I wanted to bring this to your attention that Dr. Charles Marshall, on the right of the slide, is my anatomist at the Center of Excellence in Rural Health who teaches gross anatomy. He is a graduate of Louisville, and I have a very hard time of getting him to wear UK blue to any function that we have whatsoever, even his staff shirt. But I was able to get him into a pink tutu, so. It is a joint effort when you work with the community, and that's basically what we're going to talk about today is rural health and in the community. But you have to go into that community, and if you look at my students there that are all dressed up, they're out in the community talking about prevention and preventative services. So they do add a lot of aspects of success to our center. And our slogan this year is there's too much breast cancer. So y'all join me in that fight. So our objectives today, as we take off our nursing hat, and I want to know how many of you actually still have a nursing hat. Okay. I was privileged to have two different hats. When I first graduated nursing school, I was an LPN, and we had the little pointy hat, you know, like an ice cream cone sitting on top. But I was very proud of my hat, very proud of my pen. And as I got my RN hat, I said, thank you, Lord, it's not a pointed hat. But I was very proud of that hat also and what it meant. And how many of you remember clinic shoes? How light they had to be, how clean they had to be. It was a symbol of nursing. And I do miss some of that today as we move along. But at our objectives today, we're going to look at a little bit of what rural nurses were yesterday and today, because that's where my background comes from. We're also going to look at some disparities, and you have seen some of those, but in particular, we'll look at rural on the slides I have today. We'll also look at something I'm very proud of, and that's some of the solutions that have been developed in rural health to meet those needs, and then you can ask me questions. So, when we start on our journey of knowledge, I go back to my very first learning in nursing, and it was a head-to-toe assessment. How many remember the head-to-toe assessment? Yay. We need to look at our communities in the same way. A head-to-toe assessment of what's going on in our communities, how we can be involved, and what solutions that we can come up with. Keeping in mind that we're on the sea of knowledge here, and we do look at research, we look at theory, we look at all the different things that we learn in nursing school and in our practice, but we need to look at the community and listen to the community, because if the problem is in the community, the solution is in the community. So as we're thinking about this, I want you to think about what is rural to you. When I look at this slide, this is actually a slide of a book that my grandfather showed me when I was very young. And I didn't understand what he meant by keep your arm in the car. But if you don't keep your arm in the car in a rural setting, it may be in somebody else's car before you get home. So the roads are still narrow. They still look a lot the same in the rural areas. When you talk about transportation and barriers, that comes up being the most barrier that we have in rural is transportation. Everybody says it. I had some people come from HRSA a few years ago in Washington, and I had written a grant that talked about access issues, and they wanted to truly see, is it truly hard to get from one place to the other? How many of you have been in Harlan, Kentucky? All right. Did you cross the mountain to Harlan when you went from Leslie County across? Okay. So I plan to take the director of HRSA across the mountain over into rural Harlan to show them what transportation issues we had. I promise you I had no planning in this day other than the fact that I was going to take him through Leslie County to Harlan. I got behind a log truck to start out with, and we had to slow down to like 25 miles per hour. It looked like the logs were going to fall off. He said, "Did you plan this? Did you mean for this to happen?" We know more than the log truck pulled off, and 3 coal trucks pulled out in front and hauling the coal. You don't see that as much today with as much that's going on with our mining. But he said, "I know you haven't planned this. There's no way." It took us an hour and 25 minutes to go as many miles as he could have done, and probably 30 minutes in his community. But you just can't get there from here. Have you ever heard that saying? So we have those issues that we still deal with in our rural areas, but the roads are paved a lot of times. Sometimes we end up on our home visits in roads that are not paved, that are still gravel road, but we have come a long way. So as we seek today to see what a definition is of rural, we go to the literature and you do a search, and I find it kind of funny that if you're not urban, you're rural. That's basically the definition that they came up with. If you're not metropolitan and you're not urban, then you're rural. I'll also tell you a little story about that definition. I've been a member of the National Rural Health Association for a number of years, and a committee was put together not too long ago to determine what is rural. After a year, the committee came back and they gave us a report. At the end of the year, they were still trying to figure out how, if they came to census, would they recognize that they came to census about what rural really is. So there's a lot of things that you have to look at, but the main thing I want you to take at the bottom of the slide is if you are writing a grant about rural, you need to look at their definition to put in your grant. And it's the last contact at the bottom. You can click on that and it gives you what you have to put in as your rule in the grant. And you have to go by that. So how do you picture a rural community? This is like an overhead look, and it does look between Leslie County, Harlan, and Craig County. There are lots of mountains that you go through to get to the different places, but it's a beautiful road. It's a beautiful territory. It's a beautiful place to live, and people have a great sense of pride in their community. So I'll go back a little bit farther to my roots, and though I wasn't born when Mary Breckinridge was first started this, but I was very young before she died. And I spent a lot of years at Mary Breckinridge Hospital because I was born with a birth defect, and they couldn't figure me out. So I spent a lot of time there with the nurses, and I learned to grow and respect what the nurses did. And at the time, she really believed, and I did get to meet her, and she did believe that the interventions were in the community, but she was not for the community, she was in the community. So in order to solve issues, she had to be part of that community. And so she gave a lot of advice back to the hospitals and the different clinics, and those clinics are still there today. The work that she began was in 1925, and there was not one physician, not one licensed physician in the area, no health care in the area. And if you could see pictures back in Leslie County at that time, the only passage that you had was by horseback or by wagon. And my grandfather told me many stories about it because he actually pulled the logs up on the mountain that built the first building for Mary Breckinridge Hospital. It is standing there today. It has been taken a partnership with a Appalachian Regional Hospital, but it is still there today serving people. Not the original building. The original building is now used for nursing class. All right. You all remember your nursing protocol, your morning protocol that you had in nursing. When you came on the floor at 6:30 in the morning to get report from the next shift that was leaving, and you heard about what had gone on with your patients, you had heard the head-to-toe assessment, what was necessary for discharge. How would you like to start out by making sure the shoes on your horse fit, making sure the horse was clean to go, bring it back at the end of the day and put it in the stall after you finish your work? So it's a different way of looking at rule protocol in nursing. So she's still there today as far as her legacy and as far as what she does. She had very powerful nursing leadership, and she had the will to be part of the community so that the community could have change and access to care. So I'm originally from Leslie County, and I do take great pride as being inspired by such a great group of nurses. It made me want to be a nurse at a very young age of 6. I told my family I will be a nurse one of these days. And so I hope that as nurses you take that great pride in what you do as far as being a nurse and affecting the community around you. So as we shift into the 70s and 80s, this is basically, we wanted to look back when we complained about our uniforms and how they had to be white starch and white clinic shoes. They showed us some pictures about what they used to have to wear, and we were grateful that we had our uniforms that we had. But it's changed a lot. And today I hear on the floor a lot of times that the only difference between nurses, doctors, and aides and everybody else is the name tag that they have on. So I encourage you to lift up the pride of being a nurse as you're there. I graduated the first time in 1975, and it was really different at that time as how nurses were looked upon. But something remained constant. Nurses are at the center of care of the patients that we serve, and let's not forget that. So I've had plenty of opportunities that I never dreamed that I would get, and one of them was congressional testimony. A young nurse going to Washington, first time I ever flew, and I had to fly by myself to get there. So we made out instructions on how to fly, and when I landed, how to get a cab and get to where I was going. And they're right funny today if anybody would ever like to read them. But I really enjoyed my first trip, and it also scared me to death. They set me down in a table and handed me a glass of water and began to ask questions. And I thought, you know, I've got 2 pharmaceutical reps on each side, and they're asking all these questions, and now they're coming to me. But you know, it was a great opportunity to be able to speak up for the rural people that I served and to see some change happen, and I'll show you what happened at the end. So, as we look at that, also I was able to come before our legislators here in Kentucky and talk about many issues that when we find gaps in service in our rural community, someone has to be the person to talk for them. So I really enjoyed that too, even though my legs were shaking behind the curtain. All righty. So, many changes in healthcare. I couldn't go without giving you a slide today because as the Center of Excellence in Rural Health, we have to keep up with all the changes in our state and in our nation and in our rules. So right now, with all the 48-hour rules, the readmission rates, dealing with all the MCOs and all the new changes that have come about, and being able to survive, it seems like somehow or the other, it comes around to nurses again. But if you read that, it says we need to have more patients through the hospital faster and get transfers and discharges, etc. So I decided that every time a patient was discharged, we should play the sound of cash registers ringing. Cha-ching, cha-ching. If you all keep hearing, let's get them discharged, let's no hospital readmission, we're not gonna get paid for that. And you think that this is gonna motivate nurses. That's not what nursing is about. So I just wanted to share that little cartoon with you. All right, so this is Kentucky's rural composition. And if you notice, the state is pretty much filled in with 90 of our Kentucky counties. And again, it's according to whose rule that you're saying rural is. So we have been designated the Promised Zone in Eastern Kentucky. We have been designated as SOAR, Saving Our Appalachian Region. There's all kinds of titles, but if you look within those census tracts, there's still some 15 counties that have sections that are rural in their counties. So we do have a lot in common. So we'll look at some rural challenges that we face, in 4 Americans, 7 million people live in rural areas. So there's a lot of people that need our services in rural as much as in urban. And on an average, they're older, they're poorer, they're more likely not to be insured, and they suffer from higher rates of chronic disease. Every time I come to Frankfort and we put up a map, Eastern Kentucky is always the most colorful. Our state of Kentucky is always the most colorful. We really need to work toward improving our outcomes, and I think we're all trying to come together to do the same thing in that area. Although 25% of Americans live in rural areas, only about 10% of the physicians practice there. So that gives us a real opportunity as far as nurses and nurse practitioners to be able to fill in the gaps. We heard a presentation a few minutes ago about APR in practice and how they're used in the different situations as far as the hospital and the clinics. And I think that more than ever we have the challenge and also the opportunity to step up and take care of the needs of our people. And then again, if you look at our map and you look at Appalachia and you see the little handle there, I have to show you that because we have a huge population that lives in rural Kentucky, but we also have a few counties there that more than 54 that are considered Appalachian. And when you look at southern and central and northern Appalachia, Kentucky has the most counties that are Appalachian. And then if you take a quick national rural health snapshot, and this is from the National Rural Health Association, you can see the difference in the percentages of the different things with rural versus urban. And I think you all are going to share the slides with everybody after this so that you can take a better look at that. But that is your latest. But I want to dwell on what Kentucky health disparities are here on the slides, and also show you a population that's not normally seen in any of the statistics, and that's the Kentucky home place population. Most of the time, everybody knows what birth data is, right? It's a surveillance system where they call and they interview you and survey you about health outcomes and about your health perspectives. But none of the patients that we serve in home place, some of them have access to computers and phones, but a lot of them do not. And they move around and they have track phones and their number changes a lot. So their data does not have input into that system. So a few years ago, I decided in our database we would ask the same questions as BRFIS and be able to compare to the BRFIS data so that it would be comparable and be able to tell that story. But if you look at obesity and you look at the national ranking and you look at Kentucky at 30%, our Kentucky home place population is at 47.6%. If you look at diabetes at 10.8%, 31.7% of home place population has diabetes. These are people that are hard to reach, that normally are later getting into the healthcare system. It's usually in the emergency room when they let things go until they have to go to the doctor. If you look at physical activity, if you look at smoking, the state of Kentucky 29%, Kentucky home place 35.1%. So this population does need a lot of education and a lot of help, and I'll tell you how we do that a little bit further. So now it's time to tighten up your belts and look at all the belts that we're in. So if you look at the diabetes belt, Kentucky is almost totally red. And you can see it a little better in this map. However, one of the issues that we look at is you have 48 CDEs per 1,000 diabetics. And in the non-diabetes belt, you have 208 per 1,000. So it's a maldistribution of CDEs and an ability to reach people with diabetic education. So we have to look at other solutions in reaching the people that need the education the most. So there's really some room for some collaborative work. The next belt is the stroke belt. And if you look at Kentucky, we are totally red in the stroke belt. We right now have a community health worker project that is working as a patient navigator that meets with our patients in the hospital before discharge and are part of their care while they're in the hospital, so that when they are discharged, they know who that navigator is, and the navigator is part of the coordinating team with the nurse manager in order to coordinate the care of the patients when they leave. And we have found all kinds of things that should not happen when they're discharged and things that should happen when they're discharged. So stay tuned on. It will be published. We will put it out there for information. But we have to be able to provide a way to help people through health coaching and through education and access to improve. Dr. Frieden actually visited Hazard, and he gave me full permission to use his slides, and you'll see where they came from at the bottom there. But if you look at heart disease and stroke deaths, it's higher in Eastern Kentucky than the rest of the state or the U.S. And so we also have a PCORI grant through the College of Nursing at the University of Kentucky that we're actually delivering the services in Eastern Kentucky, working with the College of Nursing, and we'll go into that in a little bit too. So if you look at physical inactivity, this is a big one, and I think we set the example as parents and as adults as what we do, the children follow. So we do have an epidemic of children that are sitting on the couch and playing all their games. And my little grandson tells me that I don't know the names of games because I said PlayStation the other day. He said, "Granny, it's so much an Xbox now. You're way behind on the games that we're playing." But how much time do they actually sit and eat snacks instead of getting out in the woods and playing like we used to when we were little? My grandmother said that TV was of the devil and you had to get out and move outside. So we got out and moved outside a whole lot. We didn't realize we were really working on a farm. We just thought we were having fun, and we really did have fun. But exercise was built into that. One day I remember chasing a horse that my grandfather told me that absolutely you can ride every horse but this one. Guess which one I wanted to ride? I was pretty stubborn as a child, and anyway, it took me a while, but I did ride the horse. But I tore down everybody's clothesline in the neighborhood by the time I finished that day. So guess who was in trouble? But it's different today. Kids are not out playing and not doing the things that they need to in physical activity. And therefore, we have an obesity epidemic. And this is my fat squirrel, and he definitely needs a diet, and he definitely needs more exercise. But you know, even squirrels plan for the winter time of what they're going to eat. They put it away. And we have to do some planning too on how to help our children learn about the proper diet, the proper exercise that they need. But as adults, we need to set that example. This is another slide from Dr. Frieden that says the total of tobacco in Kentucky, 28% more adults smoke, 8,000 each year yearly related illnesses and deaths. Our annual health care cost is $1.92 billion. Productivity loss caused by smoking, $2.3 billion. So we do have a lot of health risk and a lot of issues and a lot of things that we need to deal with. And then we look at the barriers, and as I said, transportation is one of them. But it's access to the healthcare system in itself and the lack of understanding how to navigate the healthcare system. Have you ever had a family member that comes home and says, "I'm scheduled for surgery in a few weeks and I'm not really sure what I need to do or where I need to go"? Or, you know, if you're helping your family member, you're helping them navigate the healthcare system, and it is very confusing at times. But also to access the primary care provider, the right care, the right place, and the right time, and the right cost. You know, not waiting until you are so sick that you end up in the emergency room for your care. That's not a place for primary care. Access to medications. I don't know if you realize the issues that we've had with changing with the MCOs and the different things, and people picked their plan and didn't realize the plan that they picked did not cover the medication that they were on. And so home places had to go back to writing letters to the industry drug companies to say, "Please cover this." Another gap that we had was if they signed up for Medicaid, it was a month before services started. Indigent drug companies will not provide their medicine because they are now eligible for Medicaid. So we had to back up and say they are eligible for that in a month. They will be. They will be getting services, but until that happens, they have no medication. So people were doing without heart medication, diabetic medication, their insulin, those different things that became a gap between being covered for services. And that's something you only figure out when you work in the community. Health literacy is still a big one. Education on the illness is still a big one. And this is one of my favorite people in the whole wide world. I don't know if anybody recognizes him there, because he's Dr. Bill Cordell. He's been a mentor to me throughout the years to look at access. And one of his famous statements he made, we were in a Medicare debate in Washington, and we were talking about cover just before things started really happening there as far as the thoughts of Medicare D were in the horizon. But anyway, Dr. Cordell stood up and said availability plus access does not equal utilization. And that was a big lesson for me to learn. Just because your clinic is available in the community doesn't mean that the people can actually get in your front door. So that has really steered a lot of the work and a lot of the thoughts that I've had over the years about how we provide access to care for the people that we serve. And then I guess I get to brag a little bit. This is my building here, and this is where the Center of Excellence resides. And I've been there, I've been in some facet in rural health with the center for the last 22 years. I started out as a residency nurse with the Family Practice Clinic and have moved around quite a bit in the facility to finally being the director of the facility. And I am the first nurse to be a director of the Center of Excellence in Rural Health. So that was a big accomplishment because before me, my predecessors were all MDs. And at first I got a little pushback with that. But after a little bit, we all come together and we began to work as a team. And so I'm very proud to be there. But we do serve Kentucky, and this is written in our legislation. We were legislatively written into law. And our goal is to improve the health of rural Kentuckians through education, research, service, and community engagement. And believe you me, that takes every one of my 210 employees with the center, and they are living and working in rural and very engaged in what they do. One of the first mandates that we had as a center was to look at what education was needed in rural Kentucky with the hopes that if we train people in rural, they'll stay in rural. Because as you heard this morning, the shortage of providers is in rural, like 60% of them, 61% is where the shortage is. So if we look at our education and where we train them, hopefully they'll stay there. And I'll show you a slide in a minute of how many stayed. But so we do have in our academic programs, we do have a residency program, which is our East Kentucky Family Practice Residency, where they spend 3 years with us, and they work and they live in rural. And the biggest thing about that is now we have graduates that come to our residency program that are from the area. And so the more that they're from the area, the more that they stay. Then we have the College of Health Science, which has our doctorate in physical therapy. I get about 700 applications for the program a year. We can only accept 17 students. So we get the best and the brightest in the program. They have first-time pass rates on their boards and their comps. Very proud of what they do there as compared to the students on the Lexington campus. We have a 100% pass rate. And this is real good that it stays that way. We also have our baccalaureate in health science and medical laboratory science, College of Social Work. What we do is we look at what the needs are in the community. We do an assessment, we do our research to find out in workforce what's needed in the area, and we try to bring that program to Hazard, Kentucky. And these are all of the University of Kentucky programs. In our master's program, over 640 graduates that are providing services, and 70% of them are in rural areas still working today. Our current education programs that are there is, again, I just went over those a little bit, but these are our current numbers. I'll let you see those. But here's what I'm really proud of. The civic health that we teach our students. You are part of the community, and so they do serve in the community. And one of the projects that they did was to start a free DPT program, physical therapy program, that people that could not get into the system because of insurance or other issues could have a place to go for physical therapy. And so they did start the free clinic, and they mimicked that after the free clinic in Lexington, and it's been very successful. Also with Dr. Kidsman, he has Project Carrot. This is where you can donate your used equipment, hospital beds, wheelchairs, canes, anything that is a lift, things like that. And our students take it totally apart, and they do this on their own time, but they take the equipment totally apart and they reassemble it, fixing anything and everything that is wrong with it, and is sterilized to be able to give back to the community. And they have taken really pride in that, and this is the second year that they've done that. So if you know someone in the state, it doesn't matter if you're in rural or urban, that needs assistance with equipment, please contact us there at the center and we'll be able to fit that for them. Also, they do their food and clothing drives. They collect food for the homeless shelter, provide coats in the winter. They really become a part of what the community needs are. And then this is the way that we're trying to reach in our communities to encourage people to go into healthcare. And it's called our Health Summer Camp. And our goal is to inspire these students to go in healthcare. And every summer I get the students the first thing when they come in, and I say, what do you want to be when you finish college? What do you want to go into? And they'll tell me one thing, and they write on a piece of paper and they sign their name that this is what they want to be. At the end of the 3 weeks program, I have them do the same thing again. And some of them change their mind as to what they want to be into. They get to do a virtual surgery. They get to come to UK's main campus and tour. They get to do a little bit of everything in the community. They also have to complete a research project while they're there. There is a difference. How many of you know there is a real difference between handicap accessible and wheelchair accessible? A big difference. Do you know that most of our facilities across the state didn't take that into consideration when they were building their building? So one of the projects that they did was they reviewed the nursing home, they reviewed the Veterans Center, my building, and the hospital, and we all come up short as to being wheelchair accessible. So the students really got into that. So it is a pipeline where we try to bring our students in from the summer. And this is the UK helicopter that comes and lands, and they got to do a virtual view of that. And so we work on our pipeline all the way from our elementary school in teaching prevention, in teaching health care, access to them, down to what do you want to be when you grow up. And so it's a real joy to work with the students. We were also legislatively mandated to be the Kentucky Office of Rural Health, and I have those under my wing too at the center. And they work a lot with the small hospitals, and I know you've heard about hospitals that are afraid they're going to close. We've already had one close in Kentucky already because of the new rules that have come out. And so they really have to stay on top of those issues. One of the slides that we saw just recently with the National Rural Health Association is the fact that we will lose more hospitals than we did in the 70s with the new regs that have been put in place. So just hang on. So it is a real joy to work with them. And then we also house our North Fork Valley Community Healthcare Center, and this is where our residents practice at the Center of Excellence in Rural Health, and they really get a community look about providing medicine in a rural area. They do home visits. Our community health workers actually help them on their home visits to introduce them to the community so that they can do their home visits. We do have fixed dental, and we do have mobile dental, and we do deal with 340B pharmacy. And I don't know if you've kept up with the literature, but 340B pharmacy, do you all know what that is? That's where you can buy under federal pricing. That may go away because of the Medicaid access that people have, and we're going to fight that in the Policy Institute when we go back in January. But so that is really helpful to our people, and our clinics and our FQHCs are really qualified healthcare centers that we do. We also have a mobile unit, and I apologize for the numbers. That should be 2014, and it should be over 18,000. Somehow or other, my old slide got in there. But our director of that is Dr. Nikki Stone, and her favorite slogan is, sometimes Winnie the Pooh says that you have to come out of your corner of the woods to provide services. And so she goes to the schools to provide dental services. And the first year that she did this, she came back crying, like the second visit, and she was in Leslie County. And a mother had, actually the teacher recognized the child as unable to sit in the classroom and stay awake. And the mother said she didn't know what happened to his teeth, but he couldn't eat right. Well, one exam that Dr. Stone made, every tooth was in his head, but they were swollen over with infection. And you couldn't even see his teeth. He had a temperature of 103 trying to sit in classroom. He got immediate surgery, put in the hospital, got the fever down, and had surgery to take care of the issue. But had she not made that visit to the school, I fear what might have happened to that child. But I can give you many cases like that, that is not very happy. So, education is a big part of that. And one of the parts of that is teaching children about, you've heard of Mountain Dew mouth. You know, we drink so much Mountain Dew, we drink so much sugar. So she wanted a way to teach the kids that they could understand and be able to relate that to their parents. And she came up with a drink pyramid. Can you all see that? It says water whenever. Can you all read it? I can't see it from here. Can you all read it out loud?
Water whenever.
Milk at meals. Juice just once, and pop at parties. So, then we gave the kids a quiz. We made this pyramid, and we had put Velcro on the back of it, let the kids put the milk and the pop and all that where they needed to do so that they could learn. We went to another county farther out of Eastern Kentucky, and they didn't know what pop was. You know what pop is, right? So we have to change the top of it to soda sometimes. So, but anyway, it's just the way that you teach and how the children can get access to the education and be able to understand what you're teaching them. Instead of saying you need to drink this many things a day or whatever, they look at the drink pyramid, and that has been used actually now. She has her own website if you want to look at it with the drink pyramid. So, now we get into some research. And one of the mandates of the center is research, and we are to look at health disparities, health outcomes, health policy, and workforce needs. And we work with many different partners across the state and the nation. But right now, this is just a few that I highlighted here. I could do an hour on just research projects and never get to the end of it. So I wanted to just give you a few highlights about what we do at the center. And so basically everything that we do as far as research, if you're a research partner at the center, it has to fit within our mission, and you have to be willing to come back and disseminate the findings to the community that you did the research from. That's one of the rules. And we had a thing in Eastern Kentucky about any university coming and they'd say, we want to use you in our research project. They used us. They went back and they published, and they never told us what they found. Because the people that you research don't normally read publications. And so that's one of the rules. You have to come back and disseminate what you found. And we have found that to be one of the best things in our communities, to be able to come back. I call it come sit on the porch with us. Tell us what your findings are. But so you can see that we do have the faith community involved. The Raising Awareness About Lung Cancer one was a new initiative that actually used community health workers. When we first started talking at UK about how we would come and gather this information, they talked about coming to the houses and knocking on the door and gathering a hair sample, a skin sample, blood, urine, dirt in the house, check the air radon level in the house, go outside with a garden and collect dirt, running water in the house, water that's outside the house. All these samples had to be collected. Can you imagine coming into an Appalachian community, not being from there, and knocking on the door and saying, I need to collect all these samples? You probably won't get to the front door because they don't know you. And there's all this stigma about the coal mines right now and all the coal loss, and are we criticizing the coal companies and those kind of things while we're trying to gather these samples to see in the environment where the cancer's coming from? Our community health workers were able to do that. They were able to open the doors to over 600 people to get those samples drawn. So stay tuned this April. Dr. Arnold will come back to the Center of Excellence in Rural Health and present her findings. And we have invited any of the families participants, because with lung cancer, they die very soon. And so we've invited the survivors as well as their families to come and hear what her findings are. So stay tuned to that one. I will speed up a little bit here. I know my time was a little bit shorter, but I've never had an hour before. It's usually 15, 20 minutes, so I'm having a good time. It's hard to give your life story in 10 minutes, right? But anyway, this is the one that I have worked on for the last 20 years. And when we talked about community health workers, as a nurse, I said, you're going to take people from the community and do what? There was this fear really quickly about sending people that are not trained. But believe you me, I found the missing link. They are the link to the community from the service providers. And they link the community back to the service provider. So I really have enjoyed working with them. And they do have a great mission, but the vision is what's so important, I think. And educating Kentuckians to identify their own risk factors. We don't walk in the door and say, hello, Miss Jones, I'm here to save you. We walk in the door and we say, hello, Miss Jones, how can I help you? And what kind of goals do you want to work on? Let's start with those first. And I'm famous for saying this in Washington. You can't get a mommy to come and get her pap smear if baby don't have shoes. There's just things that are more important to them to start with, and then you can get to the meat of the education and providing what they need and get that buy-in. So the community health workers are from the communities that they serve. They are recognized and are trusted by their community. When they make a home visit, they open the door for them instead of shutting the shades and locking the door. I will tell you this, when Home Place first started, they said, we'll drive state cars and we'll put the state symbol on the car. They couldn't get anybody to open the door because they thought welfare was there to take their children. You know, so we had to look at that a little bit different. And you will have to adjust things in communities. I say adjust, modify, tweak. You know, you can take interventions and move them around, not reinvent the wheel, but find a way to make it work in your community. So one of the successful things that we did that has been recognized on with the CDC and Healthy People 2020, we were also in 2010, we passed that goal. We were also featured there, but with Colon Cancer Project. And it's something that is very near and dear to me because I lost a sister to colon cancer. She was 50 years old and time for her first colon cancer screening, and she called me, she said, I'm not going. I said, yeah, you are, I'll go with you. We'll go with each other. But she had turned 50 3 days before her colonoscopy, and she had colon cancer when they found colon cancer when she had her screening. But so I advocate to get that done before age 50, and we got that into law as far as having family members with a history, but we had no history in our family whatsoever. So we did do a project, and you know what I found out in the research? When we did this, we asked questions about why do you not get your screening, and the number one answer was, what would you all think?
They don't want to find out.
That's a good one. They don't want to find out. But the number one reason is that the provider did not order it. The provider didn't talk to them about it. I was kind of shocked because I thought it would be the cost or the embarrassment. And so after this survey, we did another education with all our providers to say, what do you need? What materials do you need to talk to your patients about getting screened? And then later on, I was put on the governor's committee about colon cancer prevention, and we worked out in our East Kentucky counties with co-severance tax to pay for colonoscopies for the group. So, community health workers can reach the triple aim. Has everybody heard triple aim? It's all over your ACA, Affordable Care Act. But they are effective, and they are health coaches. They improve the health experience, improve population health, and they reduce the cost. If you think the cost is high, compare the cost of a nurse doing a home visit to a community health worker working under the nurse to provide the home visit. So there's a big cost savings there. And there is a publication there that shows that at the end. So I have been working on the core competencies of the community health worker with the state. And we are looking at having a state certification for community health workers very soon. Just stay tuned. There has to be a SPA written, and that is underway at this moment. We have some people working on that with us back here. So I appreciate her. Another thing that I'm most proud of in just the most recent days is when we had Dr. Frieden come from the CDC and Representative Hal Rogers, and we had the University of Kentucky president come. They awarded some Health Impact Awards, and this was my capstone. So, when nurses if there's students in here, when you get ready to do your capstone, do it on something that you love. I didn't want to do a retrospective review. I didn't want to do a systematic review. I wanted to work with people. And so I was very, very lucky and blessed to be able to get the money to do my capstone. Anthem Foundation gave me $150,000 to complete my capstone. We are in phase 3 with improving diabetes outcomes. And the reason I named it that is because when you raise your right hand and say, I do, you are part of your health care. You are part of making your outcomes better. And so that's the education that they get. This is a nurse-led, community health worker coordinated intervention, and it's working. People have lost weight, they have reduced their A1Cs, they have a better attitude about eating. When my research was finished, we had people in groups of 10 to 12 that were coming in for education, and we told them it was over. And I said, so we're going to celebrate. And we designed a t-shirt, and I said, what do you want your t-shirt to say? And they wanted to put, I did, I do. Well, if you write that down, it spells idiot. So it's not on their shirt, I promise you. It says, I do, improving diabetes outcomes. And on the back, they made a checklist of what they had learned. Foot care, eye care, how to eat properly. They had all the checks on the back of the shirt. I wish I brought one today to show you. But they designed what they learned on their shirt with graduation. But I was also informed that this is not over. Your funding may be gone. You may not be able to do this, but it's not over. So they formed their own support groups, and they are still meeting once a month. And they send me an agenda about what they want to learn. And this last month, they wanted to talk about foot care again and have someone fit them for shoes. And so guess what they're going to get? That's what they're going to get this month. So they don't want to disperse. They want to keep going. When we first started screening their feet, out of 12 of them, at least seven, had a place on their foot that they did not know they had. So sometimes you've got to come out of your office, go out in the community, and take their shoes off. So, and it works. So another interesting thing with community health workers, I said that Dr. Freeman and I, when we testified in Washington, we talked about Harlan, Kentucky, and Harlem, New York, and we compared cancer care. Can you imagine that? As we came together to give real-life stories about how important it was to navigate the system. But also at the same time, Sea Change had a navigation program, and they featured Kentucky Home Place. And this little man is from Jackson, and he had cancer, he had prostate cancer, and was cured 5 years into being that and developed it again. And so he became our case that we talked about in Jackson and did a phenomenal job. And if you'll go on Sea Change, you can still see the video of him as he talks about what it is to deal with cancer. And so this slide is where patient navigation that I talked about when we testified was signed into law. And that has been a few years ago, and some funding has come out of that. Some projects have come out of that. And Dr. Freeman and I actually did a project where we had a group in California, we had a group in New Orleans, Kentucky, and New York, and we did a study together. And the publication is at the end of my slides. You'll have the reference for that you can read about it. Using navigators in a hospital setting and the cost effectiveness thereof. So, but everything I do and everything that we do at the center is part of community engagement. And it is engaging the community, but the community engages us. We have, I don't know if you've heard of KVAC, but this is an educational program that was awarded to 19 districts in the school. And the first place they came to was us. How can you help us provide education in the school for the kids? That we want physical activity, we want proper nutrition, we want to be able to prevent diabetes because we have 5th and 6th graders that already have diabetes in our community schools. And so we're working very much in 19 districts to bring that prevention. And I'm hoping that we can do some form of I Do with the children. So I say that to say this, be inspired with what you do as a nursing student and as an instructor, that you can let somebody's dream come true. And it won't always happen again, but Anthem Foundation gives one of those, 1 year. I got it for 2. So it's just amazing the backing that you can get and the support that you can get when you're doing something good in your community to help the people. So again, this is night time on our building, and the page is getting ready to close on my talk here. But I really enjoy working in rural health. I say it's part of my fiber. It's part of my daily thoughts when I wake up. How can we make a difference? And how can we share that with others in our communities, our community of nursing? We have so much that we can share with each other as far as she's talking about publications and things, get it out there. It is hard to take time to write. I schedule every Wednesday as a writing day. I might get 2 hours before my door is open 90 times between 200 people. So I get phone calls from across the state, across the nation, and some international. We entertained students from China this last year that shadowed and had a wonderful opportunity with a student from Africa this past summer. So it's just, it's all about the community, but your community doesn't have to be just where you live. It can be all around you. So I appreciate the time today, and the references and at the end here is where the publications are. So I'll take any questions. Thank you. And as they say in Eastern Kentucky, y'all come see us.